our next topic, which is a very hot topic this year, is metastatic HER2 positive breast cancer. It's been a really exciting year in this field, both for clinicians and certainly for our patients. We have 3 new approvals for drugs in the advanced setting, and we finally have put the importance on brain metastasis that they deserve. So we're first going to get started with the 3 FDA approvals that we have this year. One of tucatinib added to trastuzumab and capecitabine, and then trastuzumab deruxtecan, and then neratinib and capecitabine. Kelly, could you talk to us a little bit about the HER2 CLIMB trial?
Sure. So I think this is one of the most exciting drugs to get FDA approval in the last year, mostly because the HER2 CLIMB trial on which it was based actually enrolled patients who had brain metastases that had not been treated. And those patients are typically excluded from clinical trials. So about half of their patients actually had brain mets. In our practice as breast oncologists, about half of our patients with metastatic HER2 positive disease will eventually go on to develop brain metastases. So we really need we need more drugs that cross the blood-brain barrier. So HER2 CLIMB was a large phase 2 trial that enrolled over 600 patients with metastatic HER2 positive breast cancer. And they put them in one of 2 arms, tucatinib plus infusional trastuzumab plus capecitabine versus placebo plus trastuzumab plus capecitabine. And because so many of their patients had brain mets, they also did some subgroup analyses that we'll talk about a little bit later on how those patients did as well. So for their overall population, the response rate was 40% or so for patients on tucatinib versus 23% on the control arm. Median progression-free survival in these patients, who half of which had brain metastases, was 7.8 months with tucatinib versus 5.6 in the control arm. And overall survival was improved, almost 22 months versus 17.4 in the control arm. As we know, with all of the TKIs, such as neratinib, lapatinib, they all have the side effect of diarrhea. That was also common with tucatinib. And of course, the palmar plantar erythrodysesthesia is common with capecitabine. So patients should also be monitored for hepatotoxicity. So for my practice, when you're trying to decide what the next line should be after a first line, usually taxane plus trastuzumab plus pertuzumab, I might actually consider doing a brain MRI at that point to guide my decision on where to go next, because this has been approved for the second line setting, even though in the trial, the patients had to have already had trastuzumab, pertuzumab, and TDM1. So it was a little bit of a surprise that they approved it in the second line setting, but I think it's great to have it available.
Yeah, I think that's a really good point that you bring up. I haven't thought about doing a brain MRI on patients, after they progress on the first line setting. I think the most bang for the buck in this trial is certainly in looking at the CNS endpoints and how the patients with brain metastasis did, which we'll dive into a little bit later. But I think also most importantly is the investigators in this trial, they really, they showed us what we need to do with brain endpoints from now on in a phase 3 randomized trial in HER2 positive advanced metastatic breast cancer. We just can't plan a phase 3 trial anymore without being really thoughtful about intracranial endpoints, which they did really well, and I think will be an example for us moving forward.
Absolutely.
So the next compound that I think blew everyone away is trastuzumab deruxtecan. Laura, would you mind telling us about the Destiny-01 study?
Sure. So first, just a bit about the drug. So trastuzumab deruxtecan is an antibody drug conjugate. So it's composed of an anti-HER2 antibody, trastuzumab, has a cleavable linker, and then there has a cytotoxic payload, which in this case is a topoisomerase 1 inhibitor. So this agent was granted accelerated approval by the FDA in December based on the Destiny trial. So this enrolled patients with unresectable or metastatic HER2 positive breast cancer who had received 2 or more prior anti-HER2 based regimens in the metastatic setting, and all had received trastuzumab emtansine as well. So unlike the last trial we heard of, this was a single-arm phase 2 trial, but results did demonstrate an impressive objective response rate of 60.9%, and the median progression-free survival was 16.4 months. And notably, this was a very heavily pretreated population. So actually the median number of prior therapies was 6. So these results, I think, were quite remarkable given that. But I think it's also important to note that the prescribing information for this drug does include a box warning of the risk of interstitial lung disease, and fatal outcomes from ILD actually occurred in 2.6% of patients. But I do think, this is now better understood, and I think clinicians are certainly, keeping their eye out for this. So hopefully it would be recognized earlier. And then, as we discuss a bit, results of this study were presented, really at the same time at San Antonio as the HER2 CLIMB study. So with approval of both of these treatments, there's been a lot of discussion in the breast cancer community about which regimen to favor and when.
Yes, we'll definitely get into that a little bit. I know my jaw hit the floor when I saw the waterfall plot for this drug. I mean, we just haven't seen anything like this in a patient with a median of 6 lines of therapy. I can't remember ever. I know we're young career oncologists, but I don't ever remember a water plot like that in advanced breast cancer. The other thing I thought was hilarious is somebody on that trial had 27 lines of therapy. And I was literally thinking in my head, what are the possible 27 lines of therapy that patient could have had? But that's amazing.
I think what's really interesting about the payload is that it's a topoisomerase 1 inhibitor, and we don't usually give those to our patients. So, we're not giving irinotecan to breast cancer patients.
Right.
The other thing I consider when I'm talking to patients about this is that we think TDM1 is pretty easy to tolerate, actually. This drug, they could have hair thinning and more of the side effects of a drug like irinotecan. Probably because the drug, the payload, diffuses outside of the cell, whereas
really makes it more
one stays inside.
Yeah, as you said, it's almost like it makes it more chemotherapy.
It does, yeah.
Standard effect, and you see more of those side effects.
Yeah, and just counseling patients on toxic death is kind of hard to do. I know that, all patients come in asking me about this drug, and we're giving a lot of it. We're doing sort of a registration-like thing where we're doing a baseline ILD protocol CT and PFTs at baseline, and then sort of repeating that if somebody has any pulmonary symptoms. It'll be interesting to see how that turns out, but I'll be excited to see the phase 3 trials as well and see, what the toxicity looks like in the phase 3 trials as well, because I think we just also need more information on who's at risk for pneumonitis and all of that. But an excellent option for our patients. I mean, we've seen chest wall disease just melt away after 2 doses. I mean, it's a great option.
Have you all been typically, if you're talking to patients about these 2 trial options, or now approvals, sequencing the HER2 CLIMB prior to your thoughts on trastuzumab deruxtecan? Is that typically what everyone is doing?
What my patients usually prefer is actually to do Neratinib plus capecitabine, because then they don't have to come to the infusion center during COVID. So that's our other option. Putting them on something oral is a really big deal, and not losing their hair is a really big deal.
That's a really good point. I hadn't thought of that. I think the way that I'm sequencing is pretty solely dependent on whether or not they have brain metastasis right now, and certainly what they've had previously. And everybody wants to know how we're all sequencing them. And I think that, does it really matter? I mean, these patients live for so long. I think the median overall survival at this point for advanced HER2 positive disease is somewhere in the 7-year range. So hopefully at some point through their metastatic journey, they'll have the opportunity to get both. But I think the way I'm sequencing at this point kind of depends on whether or not they have brain metastasis.
Yeah. I will say I've had some very astute patients who, and we don't have this data yet, who have asked me really about the prevention of brain metastases. And that's why one reason they're very interested in drugs like Neratinib and Tucatinib, even if they don't have a history yet of CNS disease. And there's an ongoing study in the second line looking at the combination of Tucatinib with TDM1. And I think I'm hoping they are looking at that as an outcome to see if time to brain metastases is maybe longer than average for HER2, because I think that's really one of the holy grails in HER2 positive metastatic breast cancer is, preventing brain metastases in the first place.
Absolutely.
There might be data eventually from Extenet with Neratinib in the adjuvant setting with a difference in whether or not patients develop brain metastases. So we'll just have to see.
Yeah.
And
Well, this is
brought earlier too. I know I don't know if any of you have the HER2 Compass study open, but I think in the residual disease arm there'll be access to Tucatinib. So that'll be very interesting as well.
Yeah. Well, that actually is a nice segue into the NALA trial, which was a phase 3 randomized multi-center international trial that looked at Neratinib plus capecitabine versus Lapatinib plus capecitabine in patients with metastatic HER2 positive breast cancer who have had at least 2 prior lines of therapy. In that trial, they randomized 621 patients in a 1-to-1 fashion. And the primary endpoint was investigator-assessed progression-free survival with a co-primary endpoint of overall survival. And the addition of Neratinib to capecitabine versus Lapatinib plus capecitabine did very modestly meet the primary endpoint of progression-free survival, but not of overall survival. So basically the 6 and 12-month progression-free survival was 47.2 versus 37.8, with favoring Neratinib and for 12 months it was 29% versus 15% favoring Neratinib. So modest, but a small benefit to Neratinib over Lapatinib with capecitabine. They also looked at an interesting endpoint, which was time to intervention for symptomatic CNS disease. And Neratinib was extremely modestly slightly better with an overall incidence of 22.8 versus 29%. And so I would say in this trial, a very, very modest benefit to Neratinib over Lapatinib with capecitabine. And the other very important thing to note is that Neratinib with capecitabine had a much higher grade 3 diarrhea than Lapatinib plus capecitabine did at 24% versus 12%. So it sounds like, Kelly, you're still using a decent amount of Neratinib and capecitabine.
I am, and the way that I get patients adjusted to the drug is usually a dose escalation of the Neratinib instead of the heavy use of Imodium. So I might start off with 120 milligrams for a week and then go up to 160 and then go to the full dose of 240. And for whatever reason, that dose escalation actually ameliorates the diarrhea. Same thing with capecitabine. That drug is difficult to tolerate. And if somebody gets hand-foot syndrome early on, they're probably going to just quit the drug. So I often start that at a lower dose and dose escalate as tolerated too.
Yeah, I don't know if you guys are familiar with the control study. Have you guys seen that study? Basically, they took patients on Neratinib, capecitabine, and they randomized them to diarrhea prophylaxis with either escalation or with loperamide alone, or loperamide plus cholestyramine, or loperamide plus budesonide. And the patients that got loperamide plus cholestyramine actually had pretty decent control over grade 3 diarrhea. So we have added that in our practice a bit as well. It's been really helpful. The other question is with the HER2 climb regimen and a lot of excitement over Tucatinib and using Tucatinib probably in the 3rd line for our patients with HER2 positive brain metastases. We're going to need data on TKI after TKI. I mean, will Neratinib or Lapatinib have any efficacy after progression on the HER2 climb regimen? Well, we can't talk about this topic without really diving into the specifics on intracranial efficacy of all of these agents, because I think that's really how a lot of us are determining how we're going to cycle them in the care of our patients. So next, we're going to get into the nitty-gritty of the intracranial activity from the HER2 CLIMB study that was presented this year at ESMO. Kelly, will you take us into that?
Of course. So as I said, in HER2 CLIMB, half the patients had brain metastases. They were subcategorized as untreated or treated and stable or treated and progressing. So they certainly had a patient population that was high risk for death, I would say. So even though the median progression-free survival and overall survival don't look like these giant numbers that are very impressive, the patient population was so high risk for bad outcomes that I think this is pretty impressive. So the patients with brain metastases, the median progression-free survival was essentially the same as the overall population. And they also checked for median CNS progression-free survival. So in the tucatinib arm, the median CNS progression-free survival is almost 10 months with tucatinib versus about 4 months in the control arm. The patients with brain mets also had a better survival with tucatinib of about 18 months versus 12 months in the control. So I think this was the most exciting trial for me at San Antonio last year, just because these drugs are so desperately needed, but it's easy to also go directly to trastuzumab deruxtecan and say that this is an excellent drug, but they didn't have many patients with CNS. That's what we're going to talk about next, is CNS metastases with that drug.
I think a 6-month approval in terms of intracranial progression-free survival is really significant. I agree that the 2-month overall PFS isn't very exciting, but where you get excited is a 6-month improvement in intracranial progression-free survival, where that, there's a lot of morbidity in brain metastasis, and so to be able to prolong our intracranial progression, I think, is really important. So much so that I don't know if you guys have seen this, but because the approval of tucatinib is now after 1 line of therapy, a lot of people in patients with brain mets are just totally skipping T-DM1 and going to this regimen. Yeah. What are your thoughts on that?
I think that's been a hot topic, I think, of discussion at most institutions lately. And I mean, call me a traditionalist, I don't know. I have trouble skipping the T-DM1 right now, in that the data is post, typically THP and then T-DM1. So I have been reserving this for 3rd line based on the study, but since it has been approved in the 2nd line, I wouldn't say it's wrong by any means. But I just think it leaves us with some difficulty or a data-free zone to know then when to sequence in the T-DM1.
I'd also say I think multidisciplinary discussion with radiation oncology is important. If you have someone who, got very good local therapy to their CNS disease, or perhaps, they were able just maybe a few spots and got SRS, you may feel more comfortable with T-DM1 versus someone who, perhaps had very widespread disease. So I think, thinking about where local therapy fits in has been a factor for us that we've tried to consider.
I totally agree. And I'm a traditionalist too. Everybody in HER2 CLIMB had prior HP and T-DM1. And then if you look at the Amelia trial, which was T-DM1 versus lapatinib capecitabine, there was actually a survival benefit to T-DM1 in the patients that had stable brain metastasis. So we do know that T-DM1 likely has some intracranial efficacy. I think the only patients that at my institution we've considered skipping T-DM1 and going right to HER2 CLIMB is those patients that have progressive brain metastasis. So they've had SRS or they've had whole brain and they have a progressive lesion, because really we have the best data, I think, to support that for progressive brain mets, which no one really has ever before included in a phase 3 randomized design.
The other thing that you could pull out from the Catherine trial is that patients were receiving adjuvant radiation at the same time as T-DM1 and seemed to have no more side effects than if they were not on that. I haven't tried doing brain irradiation at the same time as TDM1, but theoretically.
I think there are some reports, again, probably case reports of perhaps increased risk of radiation necrosis with the combo, but I think it's understudied overall.
I have seen those case reports, and we talk about that in our tumor board as well. I think we have a fellow looking at that, actually, radiation necrosis with concurrent TDM1.
In the brain specifically?
In the brain specifically.
We've avoided it because of that, but
yeah,
it would be good to see a comprehensive series on it.
Absolutely. So next, I want to get into the Destiny-01 study, and I think we all know that tucatinib with capecitabine and trastuzumab has very good intracranial efficacy and control. So the way we're sequencing these drugs is kind of dependent on the brain metastasis. So what do we know about intracranial efficacy, and what do we know about the brain metastasis population from Destiny-01 and trastuzumab deruxtecan? Laura, can you lead that discussion?
Sure. So there was a subgroup analysis of the Destiny-01 trial that did look at patients with CNS metastases at baseline, and they also looked in a bigger population at the CNS status upon disease progression. So as I think someone mentioned before, relatively low number of patients in this trial did have CNS metastases at baseline. So only at the dose of 5.4 mg per kg dose, only 24 of the 184 patients had baseline CNS metastases. But what was good to see is that efficacy was seen in the CNS subgroup. So the objective response rate was 58.3%, and the median PFS was 18.1 months, so very consistent with sort of the overall population. And the presentation of the abstract at ESMO Breast did feature a case report of a nice CNS response, and that sort of goes along with what we've seen with TDM1 as well, where we have seen these case reports or these case series where occasionally you do see a response. So overall, I think the subgroup analysis did demonstrate that trastuzumab deruxtecan does have efficacy, potentially in patients with a history of CNS metastases at baseline that was similar to the overall population. But compared to something like a small molecule inhibitor like tucatinib, we know this is a much larger drug, being an antibody drug conjugate. So similar to TDM1, it likely cannot easily penetrate the CNS. And I don't think we have a great understanding of why in some cases we do see activity. So I think it's, again, another area that I think a lot more study.
All that data showed me was that it seems like the patients that have stable brain metastasis did just as well extracranially as the patients that didn't have known metastasis. But Destiny-01 did not require baseline MRI or serial MRIs, I don't think. So
no, I think only a subset had that follow-up MRI. So they'd reported that at a median follow-up of 11.1 months, progression involving the brain occurred in only 4 of 48 patients assessed for that. And then that was 2 of 8 who had the baseline CNS metastases. So I agree. I think it's hard to draw a lot of conclusions from this subgroup analysis.
Right.
Would love to have some perspective or registrational studies on what the true intracranial efficacy is. I think at this point, I certainly wouldn't plan to put a patient with progressive brain metastasis or patients that had brain metastasis without local therapy unless it was really, really tiny on this compound. Yeah. So the next trial, the next compound that we're going to talk about in terms of intracranial efficacy is Neratinib, which is the pan HER inhibitor. I already discussed the NALA data, how there was a modest improvement in progression-free survival and time to CNS progression-free survival, the time to CNS intervention with Neratinib capecitabine versus lapatinib capecitabine. At San Antonio 2019, there was a poster that basically looked at the Neratinib CNS outcomes from 3 different studies. It looked at the NALA study, which is a phase 3 trial we talked about, and then the NEFERT-T study, which was actually a phase 2 randomized trial of Neratinib and paclitaxel versus paclitaxel plus trastuzumab in the first-line untreated HER2 positive metastatic breast cancer. In the overall intention to treat population, there was no difference in progression-free survival with Neratinib paclitaxel versus trastuzumab paclitaxel. But what they did do is they looked at 2-year CNS progression between the populations, and there was a difference. So only 10% of patients that got Neratinib pac had CNS progression versus 20% of patients that got trastuzumab paclitaxel. So that is actually, you know, talking about preventative in terms of CNS prevention, probably the best class of drugs to look at CNS prevention is looking like it's probably the tyrosine kinase inhibitors. And then the other trial that they looked at was TBCRC22, which was a multiple cohort study, phase 2, single arm of Neratinib and capecitabine in untreated HER2 positive brain metastasis. So in TBCRC22, the primary endpoint was actually CNS overall response rate. And the data that they presented in this particular presentation was the data from cohort 3A, which were patients that were lapatinib naive. And the overall response rate in the CNS was actually 49%, which is pretty substantial. I mean, a 50% intracranial overall response rate in untreated brain metastasis or progressive brain metastasis is great. I think so from the NEFRT trial, the NALA trial, and now TBCRC22, I think we can say that Neratinib with capecitabine certainly has intracranial efficacy. From NEFRT, what I thought about was, you know, how are we going to use Neratinib after the tucatinib, capecitabine, trastuzumab data? And, you know, I kind of thought Neratinib with paclitaxel in a patient that didn't have prior paclitaxel could be a viable option probably down the line. And certainly it's an interesting compound in terms of CNS prevention.
We're always looking for, you know, patients who are responding. You want to be able to explain to them, you know, what the hope may be, and when looking at all 3 of these trials together, what they saw was that if a patient did have an objective response in the CNS, they actually had a longer PFS and overall survival when these 3 trials were looked at together. So I think that is a hopeful statement that, you know, in these patients who have brain mets, which can be a devastating diagnosis, if there is a response, then we see some pretty promising data here.
Absolutely. And another important thing to look for, I think, in future trials and the trials that we have is the differences between intracranial progression-free survival and extracranial progression-free survival, and how do we manage both of them simultaneously and effectively. And that's always a challenge in designing trials for brain metastasis and certainly in the clinic in treating these patients. Let's see. All right, well, next we're going to move on to using trastuzumab deruxtecan in a way outside of HER2 positive or HER2 amplified breast cancer. It seems like this compound may also have activity in a sort of new subset of patients that's gained interest, I think, in the last year. And it's these patients that are HER2 low expressing. So they don't have HER2 3+ disease, they don't have HER2 2+ and FISH amplified, so they would be HER2 1+ or HER2 2+ and not amplified. Dr. Spring, can you talk about that for us?
Sure. So an ongoing trial, Destiny Breast 4, is evaluating trastuzumab deruxtecan versus investigators' choice of chemotherapy in this subset, HER2 low disease, and this is a trial for unresectable or metastatic breast cancer that was previously treated with standard chemotherapy. And as we've already discussed a bit, you know, this is an antibody drug conjugate that's quite different in that it has this notable bystander effect. So it has a high membrane permeability for the released topoisomerase 1 inhibitor payload, and therefore it's expected that it, you know, could be efficacious in these HER2 low tumors as well. So there was a phase 1 study looking at the agent in HER2 low breast cancer, and that showed an objective response rate of 37% with a median duration of response of 10.4 months. So I think clearly some activity there. And obviously this is probably a pretty heavily pretreated population as well. So we look forward to the results of this ongoing phase 3 trial.
Absolutely. I'm really excited about it in this group because really this encompasses, you know, I was trying to look in the literature, and I think HER2 low breast cancer probably encompasses about 50% of our breast cancer population. So if we were to have a targeted compound for people that would otherwise be classified as triple negative or endocrine resistant, it would be really powerful. The phase 3 trial, is it comparing it to just standard of care physician choice chemotherapy?
Yeah, there's like 3 or 4 options that the physician can choose, and they had to receive prior chemo as well. So especially for, as you said, that cohort that is estrogen positive, they've probably, you know, moved on from the endocrine therapies and have gone through some chemo. So, you know, as you said, I think this would be, hopefully will be a good option.
Absolutely. I tried to get a few patients on in the last few months after seeing this data, and I ran into some walls with COVID-19, but I think hopefully we've kind of picked up, we're sort of back where we were before in terms of trial enrollment, and I think most people are at this point. So hopefully we'll see that trial accrue quickly. I think it should accrue really quickly. Those patients are out there.
It's especially exciting for the triple negative population because you just run out of options so quickly.